Dear colleagues, it's a great honor to be a part of this meeting, and with a great pleasure, I would like to discuss with you uterine factor in RIF management. I declare that I have no conflict of interest, and I would like to discuss following uterine RIF factors today: Müllerian anomalies, uterine niche, uterine fibroids, adenomyosis, accessory cavitated uterine malformation. The topic of partial septate uterus has long remained controversial, even with regard to the very definition of what situation we call septate uterus. When using ESHRE classification, we were overdiagnosing, and according to American classification, we could miss some of the septa. But according to ISOG, the best definition from a clinical point of view is RQME criteria. In 2021, the SRM experts updated the criteria of diagnosing septate uterus, and they most agree with QME that the depth of invagination of more than 10 millimeters should be interpreted as this uterus with the septum, but the angle of invagination remained the same as in the previous ASRM classification, less than 90 degrees. It has been acknowledged that despite a diagnosis of partial septate uterus, many women will experience normal fertility and pregnancy, and only 20–25% of women will experience repeated pregnancy loss or infertility. And there is still a question: why do not all patients with a partial septate uterus do not have infertility? Why don't all patients with septum have a miscarriage? And are all septums the same? Sure that the answer is not. There is a significant clinical heterogeneity among septate uterus in length, septal thickness, and degree of vascularity. And I would like to share with you a very nice study. It was shown that septum is a real three-dimensional structure located in the myometrium, but different from it. The authors of this study were removing the entire septum as a whole structure and were able to define some histological peculiarities and different degree of vascularity. So the conclusion was that understanding the histology of the septum is mandatory, not only in determining the best surgical approach, but in understanding its pathophysiology. Some other data show that histological structural changes in the uterine septum may determine its clinical manifestations. So the pathophysiological properties of septa are determined by the peculiarities of dysembryogenesis. The uterine septa in patients with recurrent pregnancy loss are more vascularized and contain more muscle component than septa in patients with idiopathic infertility. And uterine septa in patients with infertility is characterized by lower vascularization, predominance of connective tissue, and changes in endometrial receptivity. So the mechanisms of implantation failure in case of septum might be mechanical and molecular, like uncoordinated uterine contractions, like secondary accession of endometriosis, decreased expression of HOXA10, changes in expression of pro-inflammatory cytokines and mediators in septal part of endometrium, reduction in the number of secretory and ciliated cells in the septum area. You might be familiar with this randomized controlled trial of hysteroscopic septum resection in women with reproductive disorders, which was published by Ricken in Human Reproduction in 2021. The authors found no improvements in reproductive outcomes after the intervention. But it is important to recognize several limitations of this study. First of all, it is small sample size and heterogeneity in terms of characteristics of patients' characteristics. The inclusion in the study of patient with different diagnoses, sometimes they did not have problems with infertility. The lack of information about other causes of infertility. It has its multicentral design and included multiple operators, probably with the heterogeneous techniques of hysteroscopic septum resection. So therefore, the debate on the impact of the uterine septum and its surgical correction on reproductive outcomes is still open. So here you see more recent systematic review and meta-analysis, which included 38 studies and more than 6,000 patients. Clinical pregnancy rate, live birth rate were compared in patient groups with and without septum, and in patients who were operated on those who were not operated. So pregnancies, spontaneous, and those after IRT cycles were considered, and the authors concluded that the presence of the septal uterus significantly reduces the frequency of clinical pregnancies compared to women without this congenital abnormality. The second conclusion was that the removal of the uterine septum does not increase the rate of clinical pregnancies compared to women with a remaining septum, but significantly increases the rate of live births. Here you see quite recent and large study published in 2023, which included 938 participants with septate uterus undergoing IVF. Control group was comprised of 1,500 patients undergoing IVF. Live birth rate, perinatal outcomes of surgical and non-surgical group were compared with the control group. And it was concluded that patients with a septum depth greater than 10 millimeters or 5-10 millimeters was associated with a history of unexplained infertility, RPL, RIF, and those patients might benefit from resection of the uterine septum. Interestingly, that the structure of myometrium in uterus is much more complicated than myometrium in heart. Professor Tenos presented on ESHRE 2023 the possibility to obtain so-called electrouterogram. So there is a hope that electrouterogram will enable to distinguish different subtypes of septate uterus, and it will help to identify specific characteristics helpful in predicting miscarriage, impaired implantation, or other obstetrics failures, and it will resolve a big challenge to cut or not to cut. So take-home messages will be as follows. Technical progress has made the procedure of removing the septum easier and safer. According to the literature, it is advisable to remove the septum in patients with RIF, RPL, preterm delivery. There is a need to develop additional ultrasound markers for assessing vascularization, septal structure, determination of functional features, like electrouterogram for current implantation failure patients prevention. Let's move on to discuss the next uterine area factor. So with increasing the rate of cesarean sections, the awareness of the complications after C-section is growing, and a long-term complication of C-section is a niche caused by incomplete healing of the myometrium in the site of the C-scar. And you might be familiar with ESOG document, How to Perform Sonographic Examination of Uterine Niche, published in 2019. This document will have been revised in 2022. So just a brief thesis statement about the niche isthmocele. Uterine niche is a depression in a scar after C-section of 2 millimeters and more. They might occur in 60% of scars after cesarean section, depending on technique. In transvaginal ultrasound, up to 50% of niches are not visualized without the presence of the fluid in the uterus. The niches in the non-pregnant uterus may be filled by fluid or may not contain fluid. They can be asymptomatic or have clinical manifestations. The presence of clinical symptoms does not correlate with the site of the niche. In women with a history of C-section who undergo ultrasound due to gynecological complaints, is recommended to perform liquid or gel sonohysterography if the niche is not visualized in the absence of the uterine fluid. As up to 50% of niches are not visualized without the presence of the fluid in the uterus, only by means of liquid or gel sonohysterography, the niche can be visualized, like here in this picture you see. I would like to share with you this nice study published in American Journal of Obstetrics and Gynecology. That is a retrospective cohort study conducted from 2012 till 2020. It included more than 500 of patients who underwent euploid embryo cryotransfer after PGTA. Both women after vaginal delivery and women after C-section were included. And the conclusion: of the study was that the frequency of euploid embryo implantation in cryocycle was significantly higher in the group after vaginal delivery. The only disadvantage of this study that was the sonohysterography was not performed, so the true frequency of isthmoceles is unknown. So no analysis also was performed on the frequency of implantation depending on symptomatic or asymptomatic niche. But anyway, important conclusion is that the C-section with or without isthmoceles significantly reduced implantation rate after transfer of euploid embryo compared to women with previous vaginal delivery. So mechanisms of implantation failing the uterine niche are as follows. The content of niche is embryotoxic. Negative effect of inflammatory cytokines are similar to mechanisms of implantation disruption, as in hydrosalpinx. The stagnation of menstrual blood and mucus in the niche intensifies inflammatory changes. Changes in endometrial receptivity are due to inflammatory process and as well as impaired uterine contractility. And finally, difficulties with embryo transfer can occur. So there are a few options in treating symptomatic niches, like medical treatment of symptomatic niches by means of birth control pills, IUD with levonorgestrel. So it is used, but it can be used in women without fertility plans. It's known that surgical treatment eliminates clinical symptoms of niches by 93–100% and significantly increases the thickness of residual myometrium. Clinical pregnancy rates in IVF cycles after surgical treatment of uterine niche is highly variable, ranging from 22% to 71% in different publications. But there is a great challenge and a big question whether it is necessary to treat an asymptomatic niche in a patient with secondary infertility. First of all, it remains unclear whether surgical treatment of niche can increase the frequency of implantation. Today, the use of surgical treatment of asymptomatic niche in the prevention of obstetric complication has not been proven yet. And the data on whether the size of asymptomatic niche can be an indicator for treatment are very controversial. So as you can see, the story is very complicated. So I decided to ask the question to the chatbot GPT, artificial intelligence. My question was, can asymptomatic niche be the cause of RIF? The chatbot replied that it is a very controversial question, but just in a few seconds, it presented me a meta-analysis consisting of 6 studies with more than 300 patients and showed that after resection of isthmocele, the frequency of clinical pregnancy and labors significantly increased, with the good statistical data processing shown in this meta-analysis, and concluded that resection of asymptomatic niche is a safe and effective approach to improve reproductive outcomes. But as soon as I asked him to provide me with literature resources, he immediately hung up and wrote that he would try again later. So frankly speaking, I wasn't fully satisfied with such answer, and that is why I returned back to typical data processing. Instead, the search engine gave me the huge meta-analysis of our American colleagues, which included more than 3,800 studies and was published recently in 2022. But unfortunately, this large meta-analysis included only one study about the role of surgical treatment of C-scar defect in women with secondary infertility. And here you see the study which was included. So inclusion criteria were secondary infertility for more than 2 years, sonohysterographic information of a niche, age under 35 years old, and only 56 women were included. Exclusion criteria were the presence of any other factor that can be the cause of infertility except the niche. So in other words, it was like idiopathic infertility and uterine niche was supposed to be this factor of secondary infertility. 28 patients underwent hysteroscopic resection and suturing of the uterine niche. There was a group 1, and after 6 months, they were recommended to plan a natural pregnancy for 12 months. And group 2 included 28 women also who did not undergo surgical treatment of a niche and were recommended to take a wait-to-see approach for 12 months. So the results of the study showed that the incidence of spontaneous clinical pregnancies was significantly high in the hysteroscopic uterine niche resection group, and author concluded that uterine niche may be associated with a significantly lower success rates following a euploid single embryo transfer. But currently, take-home messages are as follows. There is insufficient data to recommend niche resection to improve infertility. More clear criteria for niche resections are needed, and well-designed comparative studies are needed to determine which method of surgical treatment is optimal. Let's move on to the next factor, uterine fibroid. Many studies have confirmed the negative impact of fibroids on obstetrics outcomes, but their impact on fertility remains less clear. In this large meta-analysis involving more than 70,000 participants, Samigliano showed that fibroids were diagnosed significantly more often in patients with infertility than in patients who with no fertility problems. We know very well that the presence of submucous fibroids type 0, type 1, and 2 demonstrates significant, like 70% reduction in clinical pregnancy rate. But important question is, do other types of uterine fibroids cause implantation failure? What are the possible mechanisms of myoma's negative impact on fertility? First of all, uterine cavity distortion. The next possible mechanism is histological endometrial change, like endometrial gland distortion, elongation, cystic glandular hyperplasia, polyposis, and most frequently observed like glandular atrophy, ulceration. With the presence of myoma, we observe impaired endometrial blood supply, abnormal increased uterine contractility, chronic endometrial inflammation, abnormal local hormonal and paracrine changes, impaired gene expression, with all mentioned above can cause the impaired endometrial receptivity changes. So what about intramural fibroids that contact with the endometrium? We know that fibroids produce greater quantities of TGF-beta3, allowing those closest to uterine cavity to release more TGF-beta into endometrial cells, thereby altering BMP2 and HOXA1011 expression, and women with deficient endometrial expression of HOXA1011 experience reduced implantation rates. That may explain why, in the presence of type 3 fibroids with the size of 2 centimeters and more, the implantation decreased by 12%, clinical pregnancy rate by 16%, and live birth rate by 13%. The presence of FIGO type 4-6 fibroids with the 3-5 centimeters in diameter may reduce the implantation rate by 10%, clinical pregnancy rate by 15%, and live birth rate by 21%. What's about the surgical treatment? Here you see a single institution retrospective cohort study of infertility patients who underwent myomectomy prior to either in vitro fertilization or intrauterine insemination. The intervention group comprised of 49 women who underwent myomectomy prior to undergoing ART. And 2 separate control groups were established, like first included 76 women with fibroids left in the situ during ART process, and 103 women with no fibroids. So the results of the study show that the clinical pregnancy rate and cumulative incidence of clinical pregnancy with IVF was higher in the myomectomy group, shown here in yellow color, when compared to the patients with uterine fibroids and no fibroids group. But according to the results of the study, submucous fibroid and intramural fibroids with cavity distortion were significantly more likely to be removed during operation. And myomectomy group had a greater average number and the size of fibroids. So very heterogeneous study designs, fibroid site and location limit the interpretation of these results. I would like to share with you one more interesting study. Patients with intramural type fibroids were divided into two groups based on the frequency of uterine peristalsis. Low frequency group with less than 2 peristalsis per 3 minutes and high frequency group peristalsis. The conclusion of this study was that the clinical pregnancy rate was lower, and it was linked to abnormal uterine peristalsis caused by intramural fibroids. So maybe some additional data are needed for more consistent indications for intramural fibroids treatment. And take-home messages will be as follows: to recommend myomectomy before IVF in case of type 0, 1, 2, 3, according to FIGO classification. Type 4 fibroids in symptomatic patients. Type 5, 6, and 7 fibroids, we do not need to operate them before the first IVF. Myomectomy can be advised in case of RIF with the size more than 5 centimeter, but the size less than 5 centimeter can be also considered in case when the fibroid is adjacent to junctional zone. So the next factor is adenomyosis. We did not have clearly defined criteria for diagnosis of adenomyosis for a long time, since there was no diagnostic standard. It was so difficult to assess the impact of this pathology on infertility. And a group of world sonology experts developed the MUSA criteria, morphological uterosonographic assessment, and developed 8 well-known criteria. And it was shown that the presence of more than 4 ultrasound signs of adenomyosis, according to MUSA criteria, is in one patient. It can reduce fertility and treatment success in ART program. Diffuse adenomyosis is prognostically less favorable in the treatment of infertility than focal adenomyosis, and there is direct correlation between diffuse uterine enlargement and reproductive prognosis. But we need to remember that we treat the patient, not a sonogram, and in the absence of clinical symptoms, single sonographic signs of adenomyosis are not a predictor of success of the IVF cycle. We also need to remember that adenomyosis can coexist with different stages of endometriosis, and in this systematic review and meta-analysis with 27 observational studies and total of more than 8,000 women involved, was reported that there were no significant reduction in implantation, clinical pregnancy, or live birth rate in women with ASRM stage 1-2 endometriosis compared to women without endometriosis. At the same time, the effectiveness of IVF in infertile women with the stage 3-4 is lower than in patients without endometriosis. There is a study showing that the long-term downregulation before embryo transfer could improve pregnancy outcomes in women with adenomyosis. But we also need to remember that medical treatment of endometriosis needs urgent innovation, which should start by deeper understanding of the disease core features and diverse phenotypes, while moving from the pure hormonal treatment to drug combinations of novel molecules capable to restore various homeostatic mechanisms disrupted by endometriotic lesions, like those that are present like those that you can see in this slide, that can target microRNA, inflammation, process fibrosis, and angiogenesis, and stem cells. And the last factor which I'm going to discuss today is accessory cavitated uterine malformation. This malformation is a recently described new nosology of congenital uterine anomaly with an isolated cavitary lesion located in the lateral part of the myometrium and below or at site of attachment of round ligament of uterus. And it does not affect the normal uterine cavity and fallopian tubes. A cavity with the coarse-grained content without signs of blood supply should be differentiated from adenomyosis, uterine fibroids with necrosis, unicorn uterus, with rudimentary horn, Robert's uterus, endometrioma of the ovary. This study included 32 patients with accessory cavitated uterine malformation, and different types of treatment were performed before pregnancy planning. Laparoscopic excision, medical treatment with use of birth control pills, and sclerotherapy. And preliminary conclusion were that there is no negative effect of this malformation on fertility, and sclerotherapy is the most optimal method of preparing a patient for pregnancy. I want to express my words of support to people living in Israel. I want to express my sincere gratitude to Armed Forces of Ukraine for the possibility to be here today. And I believe that goodness will triumph over evil, and there will be a peace on earth. Thank you for attention.
Thank you to all speakers for these very nice and interesting talks. And right now is the moment for discussion. It's a very, very complex issue, recurrent implantation failure, and the endometrial factors involved in this aspect. And in the meantime, we are waiting some questions from the audience, but I would like to open a little bit debate, if I'm allowed. And I will start with Professor Macklon regarding the guidelines, the ESHRE guidelines on what we should do in a case of recurrent implantation failure. And achieving a consensus of the definition of the recurrent implantation failure is very challenging, but even much is what do we need or could offer to our patients. And the definition after cut off more than 60% of implantation rate. If it doesn't reach that, we can consider some investigation or some plan or different approaches for our patients. But today, the PGTA, that euploid embryo transfer, is performed in many cases. And as we saw the results, if we transfer 2 euploid embryos in a woman more than 40 years old, we already have more than 60%. So after 2 euploid embryos, when we are looking for some indications, we are going to the ESHRE, because it should be our North Star in what we should do. And at that point, we have done the transfer with the normal progesterone, with the normal thickness, endometrial thickness, and we transfer already 2 euploid embryos and no implantation. So according with the last definition, we can say, yes, that patient has a recurrent implantation failure. But the problem appears when we are seeing the guidelines coming from the last consensus, and all those guidelines recommend us, highly recommended, the progesterone in the luteal phases, we already done. Consider PGTA, we already done. The endometrial thickness to increase the estrogen, we already done that. And less things are there as an option to offer to that patient. And maybe when I am reading the consensus, I am a bit confused because we can have some controversial data, because it is recommended to have a testing. I don't know if this means a transcriptomy for receptivity, because it's the well-known test used or offered in our clinics today. Despite of the many randomized clinical trial, which said that the window of implantation is wide, is not so strict as that transcriptomy for receptivity test said. And there aren't any differences in our reproductive outcome if we perform the transfer according with that test or doing as a routine. So at least in the last year, 2 randomized clinical trials said that the transcriptomy for receptivity test doesn't help in that condition. But at the same time, in a guidelines, we observe that it's not recommended to test for microbiome. But when we are going to the next page, we see that antibiotics is recommended to give the women if endometritis or chronic endometritis has been diagnosed. If we are not able or not recommended to perform microbiota, why it is highly recommended or recommended antibiotic if the chronic endometritis has been diagnosed. How can we diagnose that? Only by hysteroscopy or doing immune histochemistry, which is not quite the best gold standard method on diagnosis on endometritis. So that's why I think it's very, very difficult, because recurrent implantation failure is a very, very complex and multifactorial, and that, as you said, the individualized approach should be considered, and maybe those guidelines are not the best way to be applied to everyone. I don't know if this debate is helpful to open this discussion.
Diana, thank you very much. Really great points that you raise, and it's nice actually to have an opportunity to clarify some of them. I think the starting point for any discussion of the guide is that it's not a guideline. It's a guide to good practice, and it's important to emphasize that when we were initially asked to look at this area, it became very clear very quickly that there wasn't enough evidence, strong enough evidence base to produce a clinical guideline. As I said at the beginning, we were defining the process, defining the condition is still very open to debate. But we did feel, and I do believe this, that we all recognize it when we see it in the clinic, the patient who's had several transfers, who should be pregnant and isn't, and is looking at you in a slightly accusing way as to why that's not happened. And that although the evidence base is not strong across much of the field, there was a need for clinicians to have some sort of guidance as to how to approach that situation, and that was the aim of the paper. And as you say, we went into this definition. Now, there's a few things I think I'd like to clarify on the questions that you've raised. The first is indeed this cutoff point of 60%. What it doesn't mean is that patient has a 60% chance still of conceiving in the next cycle. It means that they have had a 60% chance of conceiving and haven't, and that's quite important. And the second point is, yes, you're quite right that many of these patients will have already, depending on the context in which they're being treated, will have already had PGTA, endometrial thickness will have been checked, lifestyle factors will have been taken into account. The reason why these ones emerged as being recommended was that there was a consensus within the group that each merited reassessment, because sometimes these patients will have been under treatment for some time before they come to be assessed again, and it was worth reassessing. The PGTA, we recognized that will quite often have already been applied, and that's why we produced a separate table for identifying which patients who've had PGTA transfer of euploid embryos would then still merit. And as you rightly say, A 42-year-old or a 35-year-old or somebody under 30, if they've had 2 euploid embryos, irrespective of their age, they will have reached that 60% criteria. And if they haven't conceived after 2 euploid embryo transfers, according to the Guide to Good Practice, would merit further consideration and not just trying again. In many patients, the best thing to do is simply to try again. But the reason why we would suggest it is worthwhile doing some further considerations after the 60% has been reached is to manage the expectation of the patient and to recognize that even when you have a euploid embryo transferred, there's not a 100% chance of conceiving, which means that there may still be an endometrial or other factor meriting investigation. So to come to the specific tests that you said, I think we started with the ERA test, endometrial function tests. We're careful to use that word endometrial function test rather than endometrial receptivity test, because endometrial receptivity test tends to be assumed to refer to the ERA test, which is the transcriptomic test that's been used to identify whether or not the limited window of implantation is open or not. And as you rightly say, the recent literature in this field has raised some doubt as to the efficacy and value of that particular approach of assessing the endometrium. It is only one way of assessing the endometrium, as you've shown in your talks, Diana, and that's why we have to recognize that although in the Guide to Good Practice, it is not recommended that the ERA test be used in all patients, there may be other functional tests which you might include, actually, interestingly enough, markers of endometritis that could still be of value. This is a very rapidly moving field, as you know. There are other, while some tests are beginning to fade away, there are others that are looking very promising. And therefore, we wanted to keep that that window open, if I can call that, for people to consider some form of endometrial assessment beyond just the ERA test, because there are other ways of doing that now. To move on to the interesting discussion about the microbiome, again, rapidly moving area, and the studies are beginning to emerge now, showing a very clear association, in my view, between a disrupted vaginal microbiome and a reduced chance of implantation. I think that's becoming well demonstrated. What we still don't have are any studies showing that any intervention to address the abnormal microbiome are effective, particularly in the context of recurrent implantation failure. Now, they are again likely to come in the next few years, and it may be something that's changed. I would want to emphasize the difference that the working group ascribed to a microbiome test and a test of endometritis. So there is often some discussion about this. Quite often, a disrupted microbiome is considered to be the equivalent of vaginal dysbiosis or endometritis, depending on where you look. But I think what's emerging from the microbiome work is that there can be a disbalance in the microbiome, which does not have a clinical correlate. In other words, a woman can have no symptoms. She can have an endometrium that essentially histologically looks normal, but the microbiome, either there or in the vagina, is not optimal. And that is that space that's being developed now. So women who don't have endometritis, but could have a less than optimal microbiome, who may benefit, if studies show it, from an intervention or just waiting, because we know in many cases the microbiome, if it is abnormal, will revert back to a more normal form spontaneously. So there is that important differentiation. And that is why in the guide, we take a position on the microbiome saying it's not recommended to routinely measure it in recurrent implantation failure yet, partly because we don't have the interventions to address it. It doesn't rule it out. I think probably in the next guide, it probably will become at least to consider or recommended. We'll see. But the endometritis is different. So as you indicate, yes, we're not talking about diagnosing endometritis by a vaginal microbiome that shows a low number of lactobacilli. but rather either histological or immunohistological or hysteroscopic diagnosis, of which there are several options, and that is one of the challenges of the field, for which there are some studies to suggest that if you treat them with antibiotics, you may get a sufficient improved outcome. Shall we say enough for that to receive not a recommended, but can be considered. And I hope that addresses or clarifies the apparent discrepancies that you've picked up in the document.
Thank you very much. It was very, very useful, this discussion, because clarified all these topics, because somebody from the audience just asked what does it mean endometrial functional testing. And right now it's very clear for everybody what is that, and this is not associated or is not referring to ERA test. And another question for everybody would be, should we focus our attention only in the implantation rate or pregnancy rate, or should we have a look a bit forward, taking into account the risk of complications such as recurrent miscarriages or premature rupture of membranes or premature birth or preeclampsia? I'm going back to that because we know that endometritis affects not only the implantation, but also increase the risk of the preterm birth or the preeclampsia or other maternal conditions as inflammatory one, or the scars Professor Mikhailich described in her talk, have an important impact on this evolution of the pregnancy. So working all in assisted reproductive. Maybe we are all focusing implantation rate, pregnancy rate, miscarriages rate, and after that is something the obstetrician take care of the pregnancy. But maybe at the beginning, because we prepare the endometrium, we perform the embryo transfer, we take the care, the first steps of the placentation, maybe we could introduce those items having the look in the whole pregnancy, not just at the beginning of the implantation rate. It's just a reflection.
Good afternoon to everyone. I first of all need to tell that I'm truly delighted to share this session with two well-known and outstanding experts, and I'm really a big fan of both of you. But unfortunately, I'm not a professor yet, but Diana, after your kind introduction of me, it will stimulate me to work in this direction. Yes, I would like also to reflect this importance of the final result of the live births. And I hope that my presentation regarding the uterine niche was important, and maybe obstetrician gynecologists have had us that probably the sixth section is a big challenge for us, for a doctor in IVF field. If it is okay, I have two short questions to both of you. Is it okay to ask them right now?
I think so.
Do you hear me?
Yes.
Yeah. The first question I would like to address to Professor Markland. Again, yes, we are all curious about this document about good practice recommendations on recurrent implantation failure. And there is a recommendation to test patients with RIF on antiphospholipid antibodies. So does it mean that in RIF patients which are positive on antiphospholipid antibodies, they need the same treatment as patient with antiphospholipid syndrome? Because in the same time, in this document, it's written that the low molecular weight heparins are not recommended to increase the chance of pregnancy.
Okay, thank you for that question and for your kind introduction. It was very nice to see you. So again, let me clarify something. If you look at the recommendation around antiphospholipid syndrome or antiphospholipid antibodies, the recommendation is to look at this when there are other historical factors. In other words, a deep venous thrombosis in the past or some other evidence, clinical evidence of a thrombophilia. What is not recommended is to do routine thrombophilia screening in women without any history suggestive of clinical problems, and that's why heparin isn't recommended as a routine testing, it's a routine treatment. So I can see why the confusion arises, but I think if you look at the document, it does state that we look at only measure antiphospholipid syndrome if there is some other history, a family history or medical history suggestive of APS, and in those cases, clearly there would be a role for heparin, but not. What we're trying to discourage, perhaps, from this is what is, I think, very widespread thrombophilia testing in people with recurrent implantation failure, because in the absence of any clinical history, there is not good evidence that that is a cause of implantation failure, and therefore routine heparin in those circumstances wouldn't be advised. If I can just sort of come back to connect that to Diane's question, which is around about where does our interest and responsibility end? Of course, we're not talking about recurrent miscarriage, we're talking about recurrent implantation failure. And we often conflate those two. And I think while in some cases there may be an overlap in cause and effect, in others there won't be. I mean, as you know, one of the theories that we have espoused is that a cause of recurrent miscarriage might be excessive implantation rather than implantation failure. So they may not be, they may not share exactly the similar etiologies. And that's one reason why in the Guide to Good Practice, the endpoint here was a positive pregnancy test rather than a live birth. If I can just develop that argument that Diana suggested, that we need to take responsibility as clinicians for more than just the pregnancy test, I think we would all agree with that. And that is one of the reasons, I think, why we've recently seen this move back to natural cycle preparation of the endometrium for frozen embryo transfer. Not because there's good evidence to suggest that increases the chance of pregnancy, but because it looks as if it might reduce the risk of preeclampsia. So I think we are becoming perhaps more aware of that. The other area is BMI. If you actually look at it, the data, BMI may have a role on implantation, and certainly does on ovulation in the context of PCOS. But I think probably the main reason why we tend to get anxious about it is more for the obstetric complications rather than the fertility one. So I think it's important that we're just very clear what endpoint we're discussing when we're talking about a test or an intervention. And I hope that answers the question.
Thank you so much for such a full and very clear answer as usual. Can I ask one more question, Diana? Can I address one more question to you?
Yes.
From very practical point of view, so are there any treatment options in patients with very special and unfavorable diplotypes of HLA-F and genes of progesterone receptor enhancer? Is there something that we can implement into our daily practice?
Thank you very much. It's a very interesting question. This relationship with the desexualization and the initiation of this immune activation very must require for promoting that embryo implantation is just at the beginning. We just observed that because the sequencing on the HLA-F ended 20 months ago. So we are just observing these differences in the signature, in the genetic signature into the endometrium. And of course, all women we have studied had a normal progesterone level. So it's not a useful tool to detect which one has an unfavorable and which one has a favorable. So at the moment, it's a research. We are waiting for the decision of the fertility and sterility 3 months already to receive the publish of this paper. And of course, in the meantime, we are going on with other studies to check how can we change that, because we know that the genes cannot be changed, but maybe the transcription of them, yes, we could impact on them. So this is the next step. We don't have answers yet. We just observe the relationship and the link between the receptors and the activation and the desexualization, the stromal cells more than interleukin. So it will be, I hope, in the next maybe 2 years, we will have some answers for sure. We are working hard in this direction. So maybe in the next future, I will be able to answer with the clearest answer to that question. Thank you very much.
Thank you. Thank you. That is impressive. Thank you.
Do we have some questions from the audience? I'm looking in the chat and I can't see any other questions. So if we all agree, we can close our session, and thank you very much to all speakers, and thank you to the organizers for this invitation, and it was nice to share this panel with you both, and it was a very great and nice discussion. Thank you very much.